This is a demonstration video of the Urethroplasty flap, a versatile option for anterior urethral stricture disease. This has been performed by Associate Professor Devang Desai, a urethroplasty fellowship-trained surgeon. Case history is a 77-year-old male with a 6 cm anterior urethral stricture, ischemic in etiology, which is currently being treated with clean intermittent self-catheterization and previous failure of urethral dilatation. He suffers from significant voiding and storage lower urinary tract symptoms. He has had a 3-piece penile prosthesis inserted 10 years prior for erectile dysfunction. As demonstrated in the retrograde urethrogram, the red line marks the narrowing in the caliber of the anterior urethral lumen, indicating stricture disease. In the region of the bulbar urethra, we can see the rear tip extenders of the penile prosthesis. So why use an Urethroplasty flap in this case? The Urethroplasty flap is a technique in which a local ventral penile skin flap is used as an on-blade substitute for strictured urethra. The ventral approach is important in this case as it enables access to the penile urethra without disturbing the penile prosthesis. The local penile skin flap has a layer of well-vascularized dartos fascia which will support the flap, promoting faster healing and integration. This is of particular importance due to the ischemic nature of the patient's stricture, where a graft such as mucosal is more likely to fail due to lack of blood supply. Furthermore, the dartos fascia has a thin layer of smooth muscle tissue, which is highly elastic, allowing for a more flexible repair that withstands the stresses of normal urination. The disadvantages are that it cannot be used in patients with lichen sclerosis, as a reduced blood supply of the affected skin leads to scarring and flap necrosis. There is also risk of urethral diverticulum formation. Patient position supine, 3/0 nylon suture placed through the glands, careful not to pierce the penile prosthesis, and engage with the artery to provide caudal retraction of the penis, which enables access to the urethra ventrally. Penile skin block, not completed dorsally, to protect the penile prosthesis. Guide wire is placed by the urethral meatus into the bladder to delineate the penile urethra in the surrounding tissue. Methylene blue is injected retrograde by the urethra and in doing so visually delineates the urethral stricture from the surrounding tissue. Hemostatic clamp is placed at the base of the penis. The skin flap is marked over the glans and anterior penis to the length of the urethral stricture. There should be adequate tissue laterally for the skin flap to be used as a substitution for the defect in the urethra post-incision of the stricture. The Joshi-Kulkarni self-retractor is utilized to mimic an erection which allows for ready surgical access to the ventral surface of the penis. A midline longitudinal incision is performed on the ventral penile surface. Incision is made through skin, dartos, buccal fascias, corpus spongiosum, and then onto the urethra. The urethra is identified as it is dyed blue due to the instilled methylene blue. The penile urethra is opened at the level of the stricture in a longitudinal fashion. Incision of the stricture is undertaken till there is normal urethra proximally and distally to create a urethral plate for the graft. The proximal end of the urethral plate is marked with a suture. The left edge of the skin flap is incised and lateral dissection of the skin overlying dartos fascia is undertaken. This allows for a tension-free anastomosis of the penile skin flap to the urethral plate based on the pedicle of the supportive and vascular dartos fascia. Urethra is calibrated with a 20 French urethral sound to ensure caliber of the urethra is maintained prior to closure of the plate with the skin graft. Initial marking suture from proximal end of the medial margin of the skin flap to the left edge of the urethral plate to approximate flap. The medial margin of the skin flap is sutured to the margin of the urethral plate on the left side with 4 vicral continuous running sutures. Aim is for a watertight closure. At this stage, the medial edge of the flap has been sutured to the left side of the urethral plate and is not seen on this photo. The lateral edge of the skin flap, as marked in grey, will be sutured to the right edge of the urethral plate marked in green. The methylene blue dyed dorsal urethra over which the skin flap is sutured is visualized between the green and grey marks. The dartos flap supporting the rotated skin flap is noted by the yellow line. The edge of the two penile skin edges, which will be sutured over the flap to close the skin, are noted by the purple lines. The skin flap is rotated over a 20 French IDC, and suture is placed to approximate the lateral margin of the skin flap to the right edge of the urethral plate. Four ovicular running sutures between the skin flap and urethral plate proximally to distally is completed. As seen on the still image, the dartos is now interposed between the skin flap, incorporated into the urethral plate underneath, and the overlying penile skin, which will be closed over the top. Gland is reapproximated. Subcuticular closure of skin over skin flap and dartos fascia. Simple running sutures to reinforce the subcuticular layer of suture. Patient discharge day 2, IDC removed at 2 weeks. Patient has had significant improvement in their symptoms postoperatively. They are not requiring clean, intermittent self-catheterization. Objectively, there is significant improvement in their flow rate with Q max of 18 mils per second. Great cosmesis postoperatively is also noted.